Welcome to the Deep Dive, where we dissect essential topics for the FRCS plastic surgery exam.
Right.
Today we're focusing on congenital hand and upper limb anomalies, using congenital hand and upper limb anomalies as our guide.
This deep dive will help you understand the embryology, clinical presentations, and surgical management of common hand anomalies.
So let's get started. Let's start with general principles. What should we consider when dealing with these cases?
First and foremost, address the parents' concerns.
Okay.
Parents often experience a grieving process similar to mourning the loss of a perfect baby.
Right.
They need clear explanations, a well-defined treatment plan, and realistic expectations.
So empathy and communication are key.
Absolutely.
Yeah.
We must emphasize that many children with hand differences can achieve near normal function. Knowing about associated conditions can also prevent unnecessary and distressing workups.
Okay, so moving on to the examination. What are the essential components?
A thorough history is crucial. Inquire about pregnancy problems, the newborn period, medical comorbidities, and family history of deformities.
Okay.
Then perform a total body exam. Not just the hands. Look for a range of potential deformities, from craniofacial to the toes.
Why is a total body exam necessary?
Because congenital hand anomalies can be part of a larger syndrome.
Okay.
A thorough examination can uncover other associated deformities.
Got it. And what about surgical timing?
Consider the anesthesia risks, which are higher in children under 6 months.
Mm-hmm.
Ideal hand size for surgery is crucial, as a child's hand doubles in size in the first 2 to 2.5 years. This is especially critical for microsurgery.
Right. So waiting until the child is older may be beneficial.
Yes. Also consider the child's maturity level, their ability to cooperate with rehabilitation and splinting.
Okay.
Early restoration of hand function is vital, as it allows the child to use their hand during cognitive development.
Okay, so are there any instances where early surgery is necessary?
Absolutely. Border syndactyly reconstruction, for example, must be performed early to prevent the deformity from worsening with growth. Ideally, aim to complete all operations before school starts to aid social interaction.
Okay, that makes sense. Now let's delve into embryology, which helps us understand the origins of these anomalies. When does upper limb development take place?
Between weeks 5 and 8 of gestation.
Okay. Can you walk us through the process?
Around week 4, the upper limb bud emerges from the lateral plate mesoderm covered by ectoderm.
Okay.
This process is triggered by various factors like T-box, wingless type MMTV, and fibroblast growth factor.
And what happens if limb induction fails at this stage?
It results in tetramelia, or the absence of all 4 limbs.
So this stage is crucial for limb development.
Exactly. Now, a critical structure called the apical ectodermal ridge, or AER, forms. It's a thickening at the bud's leading edge, induced by signals from the underlying mesoderm.
Okay, and what does the AER do?
The AER induces the mesoderm to differentiate into the progress zone, which then produces morphogens to maintain the AER. This creates a feedback loop essential for limb outgrowth.
So the AER is like a conductor orchestrating limb development.
That's a good analogy. Another key player is the zone of polarizing activity, or ZPA, located on the ulnar side of the limb bud.
Okay. What role does the ZPA play?
It secretes sonic hedgehog, or SHH, along a gradient which helps determine the identity of the digits. For example, high SHH concentration leads to the formation of the little finger.
So the ZPA is responsible for the ulnar to radial patterning of the hand.
Precisely. Along with the AER and ZPA, the dorsal ectoderm also plays a role. It produces signals that differentiate the back of the hand from the palm.
So these 3 elements work together to guide limb formation.
Yes. There are 3 main interactions. The first is proximal to distal progression guided by the AER. The AER and the progress zone communicate to ensure the limb grows outwards.
And what happens if this interaction is disrupted?
It can lead to limb truncations or specific deficiencies, like thumb hypoplasia.
Okay. The second interaction is the dorsal to volar axis.
This is guided by the dorsal ectoderm and ensures the back of the hand develops differently from the palm. Disruptions here can cause abnormal dorsalization, like in nail patella syndrome, where the nails are underdeveloped.
Got it. And lastly, we have the radial to ulnar axis.
This axis is guided by the ZPA and SHH signaling. It determines the number and identity of the digits from the thumb to the little finger.
So the ZPA is responsible for the development of the ulnar side of the hand.
Correct. Diminished ZPA function can lead to a smaller hand or even the absence of the ulnar digits.
Okay. Now, how does the hand plate form?
At around 5 weeks, the hand starts as a paddle-like structure called the hand plate. This play gradually transforms into a hand with distinct fingers.
And what drives this transformation?
A combination of cell growth, programmed cell death, and the separation of the fingers.
What role does programmed cell death play in this process?
It's crucial for creating the spaces between the fingers. If this process fails, it can lead to syndactyly, where the fingers remain fused.
So syndactyly is a failure of the fingers to separate properly.
Exactly. Now let's move on to syndactyly, which is the most common congenital hand anomaly.
Okay. Can you define syndactyly for us?
Syndactyly is the congenital function of 2 or more digits. It affects about 1 in 2,000 live births and is more common in white individuals and males.
What causes syndactyly?
While the exact cause is unknown, it's thought to be a failure of programmed cell death or apoptosis between the digits during hen development.
And are there different types of syndactyly?
Yes, we can classify syndactyly based on the extent of fusion and whether it involves bones or just soft tissues.
Okay, can you elaborate on the different types?
Simple syndactyly involves only the skin and soft tissues, while complex syndactyly includes bony fusion. Complicated syndactyly is when the condition occurs as part of a syndrome.
Can you give us examples of syndromes associated with complicated syndactyly?
Poland syndrome, which involves syndactyly and chest wall abnormalities, and Apert syndrome, which presents with craniosynostosis and complex syndactyly.
So it's important to assess for other anomalies when diagnosing syndactyly.
Absolutely.
Okay.
Now, syndactyly can also be classified as incomplete, meaning the fusion doesn't extend to the fingertips, or complete where the entire digit is fused.
Is there a specific type of syndactyly associated with constriction bands?
Yes, it's called acrosyndactyly.
And what about the syndactyly seen in Apert syndrome?
That's called acrocephalous syndactyly. It involves limb abnormalities along with craniosynostosis.
Okay, how do we evaluate syndactyly?
Clinical examination is the first step, but radiographs are crucial to assess bony involvement.
Right.
Look for transverse bars and any complicated proximal joint or bony abnormalities.
Are there any limitations to using radiographs for diagnosis?
Yes, false positive and false negative results are possible due to incomplete ossification in young children. For complex cases like Apert syndrome, arteriography can be helpful, especially if multiple surgeries are anticipated.
Moving on to treatment. What are the surgical considerations for syndactyly?
Surgical timing is key. Early intervention is recommended for border digits around 4–6 months of age to prevent angular growth and deviation of the longer digit.
Why is early intervention crucial in these cases?
Because the growing finger can pull the smaller finger into an abnormal position,
Right.
early surgery can prevent this deformity.
So are there other situations where early surgery is preferred?
Yes. In complex cases like Apert syndrome, where bony components can worsen the deformity over time, early intervention is also indicated if syndactyly affects the thumb, as it can hinder opposition and pinch grip development.
What about less severe cases of syndactyly?
For most cases, reassurance and waiting until the hand is larger, usually between 6 and 12 months of age, is the best approach.
Okay.
This allows for better visualization of structures and easier handling of tissues.
Okay, so what are the key principles of surgical correction for simple syndactyly?
The main goal is to separate the fingers and create a functional web space. This usually involves using skin flaps to cover the raw areas and minimize the need for skin grafting.
And why is it important to avoid skin grafts in the web space?
Because scars and grafts in this area can contract and cause web creep.
Okay.
This can restrict finger movement and lead to recurrence of the syndactyly.
So what's the preferred technique for simple syndactyly?
The standard approach involves using interdigitated ulnar and radial-based mirror image Z-flaps.
Okay.
This technique helps create a natural-looking web space.
What are the key steps in performing this procedure?
First, make sure the flaps are large and simple. Preserve the peritonon and identify the neurovascular bundles proximally and volarly. It's important to only operate on one side of a digit during a single surgery. Multiple surgeries may be required to correct syndactyly involving multiple fingers.
Why is it important to only operate on one side of a digit at a time?
Because it helps preserve the blood supply to the finger. Operating on both sides simultaneously can compromise circulation and lead to complications.
Okay. What about the use of skin grafts in syndactyly surgery?
While we try to avoid them, skin grafts may be necessary in some cases. If using grafts, opt for full-thickness grafts with precisely templated designs.
Okay.
Bolster the grafts with a non-adherent dressing and gauze. Sutured bolsters are usually unnecessary, but you can consider steri strips if desired.
Are there any alternative techniques to using skin grafts?
Yes, the no-graft technique involves using a dorsal metacarpal artery flap to provide skin for the commissure. This technique requires careful debulking of the digit and may involve incomplete closure.
Okay. How do we address tip reconstruction during syndactyly surgery?
For optimal tip fullness and contour, you can use the Hens pulpoplasty with a composite graft or the Butt-Gramco stiletto flap. These techniques help recreate a natural-looking fingertip.
What's the postoperative management for syndactyly surgery?
A long arm cast covering the fingertips is essential to prevent operative failure from infection or early mobility. This immobilization allows the flaps and grafts to heal properly.
Okay. Now let's discuss the surgical approach for complex syndactyly.
The technique is similar to simple syndactyly, but involves dividing the bony elements while preserving the joints whenever possible.
And what are the key considerations when dealing with bony fusion?
It's important to preserve the extensor and flexor tendon slips to each separated digit. This ensures that each finger can move independently after surgery.
Is there a standardized surgical plan for complex syndactyly?
Not really. Treatment planning is done on a case-by-case basis due to the variability in presentation. The surgical plan may need to be adjusted intraoperatively based on the findings.
Okay. Next, let's move on to camptodactyly. What is it?
Camptodactyly is a congenital flexion contracture of the proximal interphalangeal, or PIP, joint. It classically affects the little finger.
And what causes camptodactyly?
The exact cause is unclear, but theories include abnormal lumbrical insertions and morphology, extra or abnormal flexor digitorum superficial slips, or abnormalities in the extensor or PIP capsular structures. Some also suggest bony abnormality of the PIP joint, especially when associated with stiffness.
Okay. How common is camptodactyly?
It affects approximately 1% of the population, though this is likely an underestimate as many cases go undiagnosed. 2/3 of patients present with bilateral involvement, and up to 20% of cases may present in adolescent females.
Is there a genetic component to camptodactyly?
It's usually sporadic, but can be inherited as an autosomal dominant trait with variable expressivity and incomplete penetrance. It's generally an isolated condition and is not considered camptodactyly when it's part of a syndrome.
Okay, let's talk about the clinical presentation of camptodactyly.
It typically presents as an abnormal flexion posture of the PIP joint, most commonly in the little finger. The flexion may be reducible or irreducible and is painless without swelling.
Okay. Are there different types of camptodactyly?
Yes. Type 1 is apparent during infancy and typically affects only the little finger. Type 2 develops during preadolescence, is more common in females, and may progress rapidly during growth spurts. Type 3 is the most severe form, involving multiple digits, and is often associated with syndromes like arthrogryposis.
What are the key features that differentiate camptodactyly from other conditions?
If the deformity can be actively reduced while stabilizing the MP joint, the issue may be MP joint instability rather than true camptodactyly. Other conditions to differentiate include arthrogryposis, symphilanism, and boutonniere deformity.
Can you elaborate on the key differentiating features?
Arthrogryposis presents with multiple joint involvement, waxy skin, and ulnar deviation. Symphilanism involves a lack of active or passive motion and absent skin creases. Boutonniere deformity usually has a history of trauma with joint swelling and DIP hyperextension.
What should we look for during the physical exam?
Note the exact degrees of flexion contracture and the degree of passive and active correction possible.
Okay.
This helps determine the severity of the condition.
What role does imaging play in diagnosing camptodactyly?
A true lateral radiograph of the PIP joint is essential to identify any bony synostosis which may be present.
Okay.
The dorsal ridge of the proximal phalanx at the PIP joint often appears chiseled or flattened. This flattened dorsal phalanx can be difficult to correct even after surgical intervention.
Let's discuss the treatment options for camptodactyly.
Non-surgical care is the mainstay of treatment. Surgery is challenging with unpredictable outcomes, and complete correction is rarely achieved.
So when is surgery considered?
Surgery is usually reserved for cases where conservative treatment fails.
Okay.
It's often necessary when the contracture is less than 60 to 90 degrees. Severe contractions exceeding 90 degrees may require early surgery, as splint fitting can be difficult.
Okay. What does non-surgical treatment for camptodactyly involve?
Splinting and stretching exercises are the primary methods.
Okay.
Splinting can be either dynamic or static. If correction is achieved with splinting, it may need to be repeated during growth spurts to maintain the correction.
What does the surgical approach for camptodactyly involve?
A stepwise approach is taken.
Okay.
This involves evaluating the volar skin, the tightness of the flexor digitorum superficialis, and the laxity of the central slip.
Hmm.
The surgical plan should address each of these components.
Okay. How do we address the soft tissue defect after releasing contracted structures?
It's typically covered with either a middle-lateral proximally based triangular rotation flap or a full-thickness skin graft. The PIP joint is then held in the corrected position with K-wires.
Now let's move on to clinodactyly.
All right.
What is it? Clinodactyly is a curvature of the finger in the radial or ulnar direction. Angulations less than 10 degrees are often considered normal variants.
Okay, and what causes clinodactyly?
It usually results from an abnormal middle phalanx. The physis may be C-shaped or bracketed around one corner of the phalangeal base.
Okay.
The phalanx itself can be triangular or trapezoidal in shape. The term delta phalanx describes this triangular shape.
Okay. How do these abnormalities affect finger growth? Both the bracketed physis and the abnormal shape of the phalanx can hinder proper longitudinal growth, leading to the curvature seen in clinodactyly.
How common is clinodactyly?
The reported incidence ranges from 1% to 19.5%. Congenital ulnar angulation of the little finger can be inherited in an autosomal dominant fashion with variable expression. Isolated clinodactyly, especially familial clinodactyly, generally doesn't indicate an underlying syndrome.
What are the clinical features of clinodactyly?
It presents as an abnormal angulation of a digit in the radial norplane.
Okay.
This most commonly annexes the little finger. Pain is not a prominent feature, and function is rarely limited. The most common site of involvement is the middle phalanx, the little finger.
Okay. How do we evaluate clinodactyly?
Plain radiographs in at least 2 views are needed to evaluate the growth plates and any bony anomalies, such as a delta or a bracketed phalanx.
What are the treatment options for clinodactyly?
Splinting is ineffective for clinodactyly.
Okay.
Most patients seek treatment for cosmetic reasons rather than functional concerns.
Right.
In these cases, surgery should be avoided as scarring can actually limit hand function.
So when is surgery indicated for clinodactyly?
Surgical correction is generally indicated for severe clinodactyly with shortening and angulation that impairs hand function, particularly for radial digits affecting pinch. Surgery is also considered when a delta phalanx is present.
What are the surgical options for clinodactyly?
One option is physiolysis, which involves resecting the bracketed portion of the longitudinal physis while preserving the growth plate and using a fat graft. This works well when a true delta phalanx is resected and can be performed when the child is around 3 to 4 years old.
What's the other surgical option?
Osteotomy, which can be closing, opening, or reverse wedge. It's indicated for trapezoidal phalanges and can be delayed until skeletal maturity. After correction, any skin deficiencies can be addressed with Z-plasty.
Let's move on to polydactyly. What is it?
Polydactyly refers to the presence of more than 5 digits on one hand. It's thought to be caused by a genetic disorder in the HOX gene or disruptions in the AER or ZPA signaling pathways.
How common is polydactyly?
It's a very common deformity, but its true incidence is difficult to determine because extra digits are often amputated in the newborn nursery. The incidence of ulnar polydactyly is about 1 in 300 for individuals of African descent and 1 in 3,000 for white individuals.
Is polydactyly inherited?
While often sporadic, it can also exhibit a strong inheritance pattern as a dominant gene with variable penetrance. This is particularly true for individuals of African descent.
Okay. Let's discuss ulnar-sided or postaxial polydactyly. Can you describe it?
It involves duplication of the little finger and is more common in individuals of African descent. There are 2 types.
Okay.
Type A involves a well-developed supernumerary digit, while Type B presents with a rudimentary and pedunculated digit.
Okay. How is ulnar-sided polydactyly treated?
For Type B with a narrow stalk, simple ligation is usually sufficient.
Sure.
This can even be done in the nursery using clips or sutures, allowing autoamputation while a cast is worn for several weeks. Type A requires operative separation with transfer of important structures like the ulnar collateral ligament and abductor digiti minimi to the adjacent finger.
What about radial polydactyly or preaxial polydactyly?
It's more common in white individuals and can present as a soft tissue, narrow stalk, or bony elements with remnants or complete tendons, ligaments, and neurovascular tissue. Surgical reconstruction for radial polydactyly tends to be more complex.
Are there any associated conditions with polydactyly?
Type B postaxial polydactyly is rarely associated with other conditions. However, Type A postaxial polydactyly has a 29% association with syndromes, warranting further workup. The presence of postaxial polydactyly in white individuals is unusual and may suggest an underlying syndrome such as chondroectodermal dysplasia or Ellis-Van Creveld syndrome.
Hmm.
Similarly, thumb duplication can be associated with systemic conditions and requires a thorough evaluation.
Okay. What imaging studies are useful for evaluating polydactyly?
Radiographic evaluation is usually unnecessary for ulnar polydactyly, but is helpful and often required for radial polydactyly. Keep in mind that radiographs can be misleading because ossification may not be complete.
Let's delve into thumb duplication. Can you tell us about the Wassel classification?
The Wassel classification categorizes thumb duplication based on the level of duplication. Type I is the least common, while type Phi is the most common. Type 7 is the most complex and involves at least one triphalangeal thumb.
Is there a modification to the Wassel classification?
Yes, the Zudum classification is a modification that adds modifiers to describe the extra digit while still using the level of duplication as described by Wassel.
Can you give us an example of how the Zudong classification is used?
Type 4, HR, would describe a thumb with a single metacarpal, an ulnar thumb with two phalanges, and a hypoplastic radial thumb with a single phalanx.
Okay, now let's discuss the treatment of polydactyly.
For a floating thumb with a narrow stalk, simple ligation is sufficient. For all other cases, except a floating thumb, it's generally best to wait until the child is between 6 and 18 months of age.
Okay.
When operating, it's crucial to preserve the epiphyseal plates. In most cases, the ulnar thumb is preserved to maintain the ulnar collateral ligament, which is essential for MP joint stability during pinch.
What about the Bilho-Cloquet procedure?
It can be considered for Wassel types I and II if the duplications are symmetrical and of equal size. However, this technique has fallen out of favor due to its technical difficulty and less favorable outcomes.
Okay.
Nail ridging, stiffness, and joint arrest can occur with this procedure.
What are the modifications to the Bilho-Cloquet procedure?
They involve preserving most of one thumb, including the physis, joint, and nail, and combining it with the soft tissue from the other thumb.
Okay.
During surgery, the nail plate should be closed meticulously, and the pulp margins should be preserved.
How do we approach Wassel type 3 duplications?
If the duplication is bifid, the Bilho-Cloquet procedure can be performed.
Okay.
Otherwise, the smaller thumb is typically excised.
What's the surgical technique for Wassel type 2?
It involves making an incision around the base of the thumb to be sacrificed, usually the radial thumb.
Okay.
This incision is extended proximally and distally using Z-plasties if necessary. The radial thumb is then carefully shelled out, preserving any usable structures such as tendons, ligaments, and skin. The neurovascular bundle of the retained thumb must be protected. The digit is then centralized on the phalanx, and the metacarpal condyle is reduced if it is significantly wide.
How do we stabilize the thumb after the procedure?
A K-wire is used to pin the thumb from the tick through the phalanges and metacarpal into the carpus to maintain the reduction.
Okay. What about the collateral ligaments?
They are reconstructed either by preserving their insertions or reattaching them to the remaining thumb.
Okay. What do we do with the tendons?
The eccentric, extensor, and flexor tendons are repositioned, and you may consider supplementing the remaining thumb with tendons from the sacrificed side. The abductor pollicis brevis should be identified and either reattached or preserved.
How are Wassel types V and Sives treated?
The basal joint and metacarpals are reconstructed with osteotomy.
Okay. Now let's discuss macrodactyly. What is it?
Macrodactyly is characterized by overgrowth of one or more digits. The prevailing theory suggests nerve-stimulated pathology, with abnormal neural control within the distribution of a peripheral nerve.
Okay.
This is often referred to as nerve territory-oriented macrodactyly.
How common is macrodactyly?
It's uncommon, affecting just over 1% of all upper extremity anomalies.
Okay.
It typically occurs sporadically and is classified into 4 types as described by Upton.
Okay. Can you describe the different types of macrodactyly?
Type I involves lipofibromatosis of the nerve and is divided into static and progressive subtypes. In the static subtype, the enlarged digit is present at birth and enlarges proportionally with age. The progressive subtype presents with a near normal digit at birth, but by age 3, the digit begins to enlarge disproportionately. Type 2 is associated with neurofibromatosis, or von Recklinghausen's disease. Type 3 is very rare and characterized by macrodactyly with hyperostosis. Type 4 involves macrodactyly with hemihypertrophy.
Are there any associated conditions with macrodactyly?
While usually isolated, it can be associated with neurofibromatosis, Klippel-Trenaunay-Weber syndrome, and limb hypertrophy.
What conditions should we differentiate macrodactyly from?
It's essential to differentiate it from other conditions such as tumors, vascular malformations, and lymphedema.
Let's talk about the anatomy of macrodactyly. What are the key features?
The skeleton is enlarged with advanced bone age compared to normal digits.
Okay.
The soft tissues are also diffusely enlarged, and osteoarthritic changes may present early. One of the digital arteries is often enlarged as well. Fatty infiltration of the digital nerves is common, leading to significant enlargement. A thickened flexor sheath may cause triggering.
Okay. What are the clinical features of macrodactyly?
It presents as enlarged digits, often with angular deformity. Radial digits tend to deviate radially, while ulnar digits deviate ulnarly.
Okay.
Nerve hypertrophy can lead to compression neuropathy. Although osseous growth stops at skeletal maturity, soft tissue enlargement may continue throughout adulthood. Approximately 10% of macrodactyly cases are also associated with syndactyly.
Okay. Can you describe the clinical presentation of each type of macrodactyly?
In type 1, the index and middle fingers are most commonly involved, and multiple digits are usually affected.
Oh.
There's a predilection for the median nerve distribution, and 90% of cases are unilateral. Type I often presents with hyperextension due to greater volar growth compared to dorsal growth and clinodactyly.
Okay.
Type 2 presents with the classic signs of neurofibromatosis. These include 6 or more café-au-lait spots and multiple nodular peripheral nerve tumors. Neurofibromatosis is an autosomal dominant condition, and skeletal abnormalities like scoliosis, bowing, and tibial pseudarthrosis may be present in about 30% of cases. Seizures and mental retardation are also possible. Type 2 is often bilateral.
What about type 3?
It's characterized by osteochondral periarticular masses that cause significant loss of motion and finger nodularity.
Okay.
Abnormal nerves are not typically present in this type, and incision scars are prone to hypertrophy.
And type 4?
Type 4 encompasses several forms, including segmental gigantism, hemihypertrophy, and cross-gigantism. In segmental gigantism, only part of the limb is affected. Hemihypertrophy involves one side of the body and may be associated with neurofibromatosis or Klippel-Trenaunay-Weber syndrome. Cross-gigantism affects regions on both sides of the body.
Okay.
Type 4 typically presents with ulnar drift and flexion contractures of the MP joints. The thenar and hypothenar eminences are enlarged, leading to adduction contracture of the thumb. Renal, adrenal, and brain involvement may also be present.
What imaging studies are helpful for evaluating macrodactyly?
Comparison plane radiographs are necessary to document growth variation. Arteriograms or MRAs may be needed to rule out vascular malformations.
Let's discuss the treatment of macrodactyly.
Treatment often requires repeat surgery and may be indicated for both aesthetic and functional reasons. It's essential to understand that the involved digit will never be completely normal.
Okay.
The goals of treatment are to control or reduce the size of the digit, maintain sensibility, and preserve useful motion, particularly in the thumb. Common procedures include nerve decompression if nerve enlargement leads to compression neuropathy.
How can we limit growth in macrodactyly?
Growth limitation can be achieved through epiphysiodesis or growth plate ablation.
Okay.
This is typically done when the affected digit reaches the same length as the corresponding digit in the parent and can be combined with corrective osteotomy for angular deformities.
Okay.
Other less reliable methods for growth limitation include digital nerve stripping, digital artery ligation, and compression bandaging.
What other procedures can be performed for macrodactyly?
Skin and subcutaneous tissue resection can help to reduce bulk. Wedge osteotomies can correct angular deformity. Various bony shortening procedures can also be performed, such as multiple osteotomies, distal phalanx resection, and arthrodesis.
Is amputation ever considered for macrodactyly?
Yes, amputation may be a viable option. Ray amputation is considered for border digits, while transmetacarpal amputation of central digits with adjacent digit transposition is an option for more central digits. Amputation is a reasonable option for many digits, especially in cases that are grotesque or functionally limiting. This should be discussed with the family early on.
Are there any challenges associated with the surgical treatment of macrodactyly?
Yes, it's important to note that many described procedures for macrodactyly are often unsatisfactory and may create further deformities, requiring additional surgery.
Okay. That concludes our discussion on macrodactyly. Now let's move on to another important topic.
Sure, what would you like to cover next? Let's discuss hypoplastic thumbs, which present unique challenges.
Okay. What are the key considerations when evaluating a hypoplastic thumb?
First, determine if it's a true hypoplasia or simply a delayed presentation.
Okay.
Thumbs can be classified based on severity, ranging from type I with minor hypoplasia to type V representing complete absence.
Okay. How does this classification guide treatment decisions?
It helps determine whether thumb reconstruction is necessary. In mild cases, observation and therapy may be sufficient, while in severe cases, policization or reconstruction using a toe transfer might be indicated.
What are the goals of thumb reconstruction?
To provide a stable, opposable thumb that allows for pinch and grasp. This improves hand function and overall quality of life for the patient.
Okay. Let's move on to radial longitudinal deficiency, or radial club hand. It's a complex condition with varying presentations.
Indeed, it involves underdevelopment or absence of the radius, often accompanied by thumb hypoplasia or abscess.
What causes radial longitudinal deficiency?
The exact cause is unknown, but it's thought to be due to a disruption in the apical ectodermal ridge, or AER, during limb development.
How does the severity of radial deficiency affect treatment?
Treatment depends on the severity of the deformity and the presence of associated anomalies, like cardiac or skeletal abnormalities.
Okay. What are the treatment options for radial longitudinal deficiency?
Non-surgical management involves stretching and splinting to address wrist and forearm contractures. Surgical options include centralization of the hand over the ulna, radialization osteotomy, and tendon transfers.
Okay. What are the goals of surgical intervention in radial longitudinal deficiency?
To improve hand function and appearance by correcting the wrist alignment and restoring thumb function if possible.
Let's switch gears and discuss congenital trigger thumb. It's a common condition that can be quite distressing for parents.
Yes, it presents as a snapping or locking of the thumb when it's flexed or extended.
What causes congenital trigger thumb?
It's due to a thickening of the flexor pollicis longus tendon sheath, which creates a nodule that gets stuck at the A1 pulley.
Okay. How is congenital trigger thumb diagnosed?
Diagnosis is primarily clinical, based on the characteristic snapping or locking. A palpable nodule may be present in the palm.
What's the treatment for congenital trigger thumb?
In most cases, observation is sufficient as the condition often resolves spontaneously by 1 year of age. If triggering persists beyond that, surgical release of the A1 pulley is indicated.
Okay. Let's talk about another common hand anomaly. Symbricodactyly. It involves a spectrum of digital anomalies.
Indeed, symbricodactyly encompasses short, webbed, or absent fingers. It can range from mild hypoplasia to complete absence of the fingers.
What are the different types of symbricodactyly?
There are several classification systems. The most commonly used is the Blouth classification, which categorizes symbricodactyly into 5 types based on the severity and complexity of the deformity.
Okay. How does the Blouth classification guide treatment?
It helps determine the most appropriate surgical intervention, ranging from simple procedures like web space deepening to complex reconstructions using toe transfers.
Now let's move on to arthrogryposis multiplex congenita. It's a broad term encompassing multiple congenital joint contractures.
Right. Arthrogryposis is characterized by non-progressive joint contractures present at birth. It affects multiple body areas, but will focus on the upper limb involvement.
What causes arthrogryposis?
The exact cause is often unknown, but it's thought to be due to fetal akinesia or decreased fetal movement during pregnancy.
Okay.
This can result from various factors, including maternal illness, neurologic abnormalities, or uterine constraints.
Okay. How are upper limbs affected in arthrogryposis?
Upper limb involvement varies, but common presentations include shoulder internal rotation, elbow flexion, wrist flexion, and ulnar deviation, finger contractures, and thumb and palm deformity.
What are the treatment goals for upper limb arthrogryposis?
The main goals are to improve function and independence by addressing the joint contractures, maximizing range of motion, and providing adaptive equipment.
Okay. How is upper limb arthrogryposis managed?
Treatment is individualized and often involves a multidisciplinary approach. It includes non-surgical interventions like stretching, splinting, and serial casting, and surgical procedures like tendon releases, capsulotomies, and osteotomies.
Okay. Let's discuss cleft hand, also known as ectrodactyly. It's a rare condition where the central part of the hand is missing.
Right. Cleft hand can be categorized as either typical or atypical. Typical cleft hand presents with a V-shaped cleft separating the radial and ulnar rays, while atypical cleft hand has more complex and variable presentations.
What causes cleft hand?
The exact etiology is unknown, but it's thought to be due to a disruption in the apical ectodermal ridge during limb development.
How is cleft hand managed?
Treatment focuses on improving hand function and appearance. It can range from simple procedures like pellicization for a missing thumb to complex reconstructions involving bone grafts and soft tissue flaps.
Finally, let's touch on congenital constriction band syndrome. It can have serious consequences for the affected limb.
Yes. Congenital constriction band syndrome occurs when amniotic bands constrict a developing limb. It can cause a range of deformities, from simple indentations to complete amputations.
What are the implications of congenital constriction band syndrome?
It can lead to lymphedema, impaired circulation, and even autoamputation of the affected part. Treatment often involves surgical release of the bands and reconstruction of the affected tissues.
Okay, that wraps up our review of common congenital hand and upper limb anomalies. Let's move on to some key takeaways.
Okay, remember that early diagnosis and intervention are crucial for optimizing outcomes in these patients.
Right.
A thorough understanding of embryology helps us understand the underlying causes of these anomalies.
Absolutely. And a comprehensive physical exam, including a total body assessment, is essential to identify associated conditions.
Yes.
Okay.
Surgical management should be tailored to the individual patient, considering their specific needs and the severity of the deformity.
And it's important to involve a multidisciplinary team, including hand therapists, occupational therapists, and geneticists for optimal care.
Definitely.
Okay.
Lastly, remember that parental education and support are vital throughout the treatment journey.
That concludes our deep dive into congenital hand anomalies. You've now gained valuable insights into embryology, clinical presentations, surgical management, and key considerations for various hand conditions.
Remember that this deep dive serves as a high-yield review for the FRCS exam. We encourage you to continue exploring the recommended resource, Congenital Hand and Upper Limb Anomalies, for a more comprehensive understanding.
Best of luck with your exam preparation.